Okay, well, thanks everyone for coming. If you can just advance to the next slide, I'll go ahead and talk to you all about my grill topic today, which is unclear on clearance, all the unique renal function estimation considerations, as well as some new changes from recent publication updates, and along with that, some renal clinical alert solutions. Next slide. Some of the objectives of this grill are to identify some optimal methods of estimating creatinine clearance in some patient populations that we don't think about too often. So some of those more special patient populations, focusing on non-dialysis patients, because that would be an entirely separate topic. And then afterwards, we'll dissect more on what clinical decision support is and sort of optimization strategies to minimize user alert fatigue, which then lends itself to the last objective, which is assessing advantages and disadvantages to using clinical decision or CDS tools specifically in renal clinical decisions. Next slide. So to start off, I'll provide this patient case for you to think about as we go through this slide. TM is a 70-year-old, 5'6", 80-kilogram quadriplegic male with a past medical history of diabetes and smoking, and they were admitted to the general medicine service with a lower extremity wound concerning for a recurrent infection. The patient has had roughly 200 milliliters of urine output in the past 5 hours and no prior history of CKD. Next slide. So to provide an overview of why renal dosing and why our role as pharmacists is so important, I like to emphasize the prevalence of CKD and AKI or kidney and renal dysfunction in general in the US. So around 37 million people in the US have some form of chronic renal impairment, and the prevalence tends to increase with age. In people age 65 and older, it seems like the CKD rates rise up to as much as 38%, and as many as 9 in 10 adults with CKD don't know that they have CKD. The one-year mortality for hospitalization for AKI versus non-AKI is also relatively high at 28 versus 14%. And that's taken from an analysis done for a 14-year period from 2000 to 2014. And the rates of AKI haven't improved much since the 70s or 80s. So this is a constant issue that we've had to experience in the inpatient hospital setting. Next slide. So now that you have that background, I want to go into how you can utilize some of the tools that we learned in pharmacy school and utilize as practicing pharmacists to estimate creatinine clearance. So next slide. We can go over why we use creatinine in the first place as a tool to estimate our renal function. Well, creatinine, as we know, is a metabolite of muscle breakdown. It's created from the conversion of creatinine and phosphocreatinine. And so then the creatinine made is proportional to the muscle mass that we have. So we use it as an analog, a different metric to kind of estimate how much our renal function is in comparison to an otherwise healthy individual. It's also more cost effective than other biomarkers out there. That's also another talk that could be done, full grill on inulin, cystatin C, and there's as many as 17 other different biomarkers available to estimate renal function. But creatinine is the most readily available one for a lot of hospital systems, including our own. And there are downsides to using creatinine for, as we'll identify later in this presentation, but we often identify an overestimation of renal clearance in specific cases. Those cases include mild to moderate renal dysfunction due to the fact that there's around 15% of hypersecretion of creatinine in the proximal tubular cells. And so when renal dysfunction worsens, we end up seeing an overestimation in a lot of our creatinine clearance formulas that were created. We also see a lot of medications interfering with our creatinine clearance predictions. As exampled here, trimethoprim and cimetidine, they also block creatinine secretion at that proximal tubular cell location, again, leading to overestimation using our regular formulas. And because a step in the formation of creatinine is involved with liver function, cirrhosis can also play a role in causing overestimation of renal clearance, since creatinine is involved in liver breakdown via methylation of some of its byproducts that can increase serum creatinine levels. Next slide. So there are also some factors that might also impact creatinine production here. A lot of these are ones that are fairly well known, such as aging. The older individuals are, the more likely you are to have a decreased serum creatinine. Female sex likely to have also decreased levels of serum creatinine and muscle mass, as well as some other factors listed below. And the one that I want to point out specifically is race or ethnic group in particular is highlighted in this table. And this is a study taken from the early 2000s. And since then, we've actually identified that race is something that may or may not play a role in serum creatinine and renal function as a whole, due to the fact that a lot of studies were initially focused on predominantly white males. There's a lot of reevaluations being done and a lot of new publications indicating that with appropriate minor modifications to our creatinine clearance formulas, we have seen that race is more of a social construct and not necessarily indicating that renal function is better or worse in comparison to the white population that was initially what we had studied the formulas in. Next slide. So before I get into special populations, I wanted to review what standard creatinine clearance estimation equations or formulas look like. So a mild refresher from our pharmacy school years, as well as some updates from some recent publication changes or publications that provided changes to the formulas. So next slide. To start off, Cockcroft-Gault. This is one that typically all pharmacists have in the back of their pocket. It is widely applied and generalizable to a lot of individuals. We do have a correction factor for females just based on the smaller muscle mass typically. But this is one of the early formulas that was originally studied in the 1970s. And again, with that predominantly male population in a creatinine clearance range of around 30 to 130. So they did get a large data set of individuals with varying renal dysfunction. But this one typically overestimates renal function by around 10 to 20% in most because of the tubular secretion. And this equation also does not adjust for body surface area. Next slide. In comes the MDRD equation. So this one was developed in 1999. This initial study evaluated the creatinine clearance of around 1,500 individuals. So this was a fairly big sample size. And the equation was adjusted, and you see the adjusted equation here after 2005 to account for a difference in testing of the serum creatinine assays. So this one does adjust for body surface area, and it's most accurate if you suspect that the patient has some level of renal dysfunction at baseline, so typically less than 60 milliliters per minute. And the adjustments I have for race are more for contextual basis. Those are slowly being done away with, again, as I mentioned, reviewing the previous data and identifying if those corrections are still needed. Next slide. The newest formula that has had recent changes is the CKD-EPI equation. This was created in 2009 and has since been readjusted in 2021 to do away with race. So what they did was they reviewed the information and created a new calculation that does not account for that. And it solely accounts for age and if an individual is female or male. So if you go to the next slide, because I know that that equation is a little confusing, I have for reference a list here of what serum creatinine criteria would fit this equation, since it is more challenging to do as a bedside formula, but this shows a better breakdown. Next slide. Then we also have the modified Schwartz equation. So the Schwartz formula, switching gears, the previous formulas are used in mainly adult populations. There wasn't a formula created for pediatrics specifically until the Schwartz formula in the 1970s, also developed pretty early on, and was adjusted to standardize the K, or the constant, to instead of provide variation for different age groups of pediatrics. This is an equation that's a little more readily available at bedside, a faster calculation to do. And as you see in the graph to the right, this is identifying the fact that this is validated across a lot of different renal dysfunction. So the slope of the graph indicates how accurate this Schwartz equation, this modified Schwartz equation, can be in predicting based on renal function and age. And as you can see, it's a decently tight fit, or fit enough for us to be able to use. There's a lengthier equation that yields a little tighter of a fit, where around 88% of patients that are using this estimate fit within 10% variability of other biomarkers such as inulin or cystatin C. But this is a pretty good equation to utilize kind of moving forward in pediatrics. Next slide. And then the last equation that we commonly see for adjustments overall is the Salazar-Korakhan. That is an equation that's used to adjust for obesity. So in cases where we have a BMI greater than 30, we've also identified that this correlates with an improved estimation of renal function. Next slide. So now that I did some background in reviewing some of our common renal function equations, wanted to delve deeper into considerations of when those renal function equations and formulas do not really apply as well. So if you go into the next slide. The first special population I want to target is one that I anecdotally see a lot in our surgical patients. That is the spinal cord injury patient classification. So here I have us walking through one retrospective review done by the VA with a small subset of 87 patients that had longstanding spinal cord injuries, and they had identified these patients over a year period, so 2009 to 2010, or a 6-month period, apologies. And they had been given vancomycin and had used that vancomycin to monitor if their renal function was improving or declining. So they used baseline individuals that had otherwise good renal function as a baseline for appropriate vancomycin clearance. And then they had identified these spinal cord injury patients who were given at least one vancomycin level during their hospitalization. And the main outcome was to identify the mean prediction error of these 6 renal function formulas that they had utilized. So the main one that they had identified was using this correction factor of 2.3. They used a modified Cockcroft-Gault equation where they had used adjusted body weight if they were less than ideal body weight, and if the serum creatinine was less than 1, they rounded it to 1. Otherwise, it's the standard Cockcroft-Gault equation that they used. They took it to the exponential power of 0.7 and multiplied by that correction factor of 2.3, and compared it to some of the other equations that I had previously reviewed. So next slide. So this is the breakdown of all of the equations that were compared. And as I mentioned, the main objective of this was to identify the mean prediction error. And they had identified that the spinal cord injury one had the tightest fit and the least amount of variability in comparison to all the other equations. If you go to the next slide. So you can further see that a lot of the equations provided overestimations of creatinine clearance. And the study is slightly biased because their p-value was only marginally above their what they determined to be clinically significant. So given the N of 87, there needs to be some evaluation further in other patient populations to really see if this equation can be used widespread. But in their population of VA patients, which often includes elderly male patients above 65 years of age, this study does show that this formula can be validated within the patient population criteria that they had identified. Next slide. So moving on from spinal cord injury patients, another surgical area is a lot of individuals that have amputations. So this can be prevalent actually outside of surgery as well. You can certainly have patients who've had diabetic issues or other blunt traumas that caused a reason for them to have an amputation. And unfortunately, there is minimal literature in identifying any renal adjustments that we can make to the standard formulas that we have to really parse out what their true renal function is. We do know that there is a difference because their muscle mass changes. So what we can do is instead utilize the Osterkamp method of adjusting their body weight and utilizing that as a comparison for what their ideal body weight should be. So similarly to how we break down burn patients into sections of their body surface area, we have the Osterkamp method, which breaks down components of your body into different percentages of the whole. So you can identify what the patient's ideal body weight should be and adjust that for their amputations. And this is something that isn't readily done within the EPIC, our vendors' software. So it's an important consideration to make when you're looking and evaluating for your patient's renal function. This is something that you can do to manually adjust and potentially get a slightly better renal function estimate. Next slide. Now, we also have transgender patients as a pretty common special population that we get. There also isn't a lot of data to really guide our decisions as pharmacists in terms of how we would renally dose, though there were 4 published studies to indicate the impact of hormone therapy on this subset. So in total, all of those studies had a combined 164 patients evaluated. Each study identified roughly 20 patients in their treatment arms. And what they identified is that it's hard to utilize lean body mass as an indicator of, as a true indicator of whether or not they should utilize one gender identity versus sex at birth. There was conflicting studies on that. So we have seen that serum creatinine can adjust as soon as 3 months after initiation, but because we don't have a full consensus, the standard is to utilize 6 months as a marker that hormone therapy is complete and that the patient has transitioned successfully. And so in that case, this literature review taken from multiple individuals from Yale, Mayo Clinic, and other academic medical centers, they created this consensus that at 6 months, we can consider the patient's gender identity as what we should utilize for creatinine clearance formulas. And if the patient has either no hormone therapy or is below that 6 month cutoff, then we can use sex at birth. And then next slide. Now, the last patient population that I wanted to talk about is pediatrics. So in pediatric population, as I alluded to when I briefly touched on the modified Schwartz equation or the bedside Schwartz equation, it changes pretty significantly based on age. And that complicates things, especially when you're trying to track this moving target when the patient also has potentially renal dysfunction on top of that. So below here is a table indicating estimates of what serum creatinine typically looks like depending on the age of the patient. So within the first few months of age, the serum creatinine is slightly higher, and that's mainly because that's also factoring in the mother's serum creatinine. But as they progress in age, decline slightly, and then around 1 to 3 years of age and up, it slowly then goes back up to what we see in our general adult ranges. Next slide. So our current practice is the one that I had mentioned, the Schwartz equation. But then there was another evaluation of the Schwartz equation that examined a lot of these new formulas and compared them using medications that were highly renally cleared to use that as a baseline to see if these formulas were able to appropriately predict the patient's renal function. So if you go to the next slide, you'll see that these were broken down into patients who are from 0 to 1 year of age and then 1 year to 12 years of age. And in this plot, you can see the dot represents the mean of the renal function to true creatinine clearance ratio. So anything close to 1 indicates that the formula is functioning as it should, as appropriately estimating the renal function. Anything above that indicates an overestimation of renal function. Anything below indicates an underestimation. So if you go to the next slide, you'll see our Schwartz equation highlighted in red is relatively close and within the confidence interval listed there. It does show that that can accurately predict renal function. But there's also these two other equations, the Flanders metadata and the Lund-Malmo, that are taken from non-US populations. But for reference, I can provide them for anyone who's interested. They did perform equally as well to the Betschreidt-Schwartz equation, and they're just simply more involved equations that have more constants, but they contain the same information: age, height, and serum creatinine. Next slide. So now I'm finally turning back to the patient case. So TM, again, is a 70-year-old, 5'6", 80-kilogram quadriplegic male with a past medical history of diabetes and smoking. And they were admitted for that recurrent infection. So if you go on to the next slide. To simplify things, I calculated an estimated creatinine clearance using the modified Cockcroft-Gault equation of 100 milliliters per minute. And the team wants to use vancomycin to empirically cover for a patient's infection. So using the clearance for spinal cord injury patients, the clearance formula, as well as our vancomycin protocol, what initial maintenance dose would you recommend? And as an asterisk, this is not validated per our protocol, but this is just a hypothetical for you to use this. I'll give people a minute to use their scientific calculator on the horizontal mode of your phone. Yep, so I saw, I know it might take a little bit, so for the interest of time, I'll do the next slide. So I saw in the chat, C is correct. I want to showcase this to show the dramatic difference that this renal function formula can actually make in comparison to what we would use as our standard, the Cockcroft-Gault. As you see, their renal function might live closer to the 50-60 range as opposed to 100. Next slide. So now that I showed multiple factors that can influence how we interpret a patient's serum creatinine, there's a fair amount of clinical gray area that we've identified. And there's a lot of research that needs to be done to better validate some of those predictive models for renal function. But on the plus side, I wanted to switch gears and focus on what information we do have about renal function and what we can use from the informatics side of things to help healthcare practitioners, and that is mainly in the form of clinical decision support. Next slide. So what is CDS? Clinical decision support is a tool that can use relevant clinical information and put it up front and available really readily to all healthcare workers. There's two forms of it. that we can classify, non-integrated, and those are outside materials that we can populate into the system, so guidelines, or integrated. So those are simple adjustments that we can do to preset patient data that can either draw your attention in the form of highlighting specific lab values, or things that are more advanced, such as flagging if a patient requires a renally dosed change their medication. Next slide. So with creating a clinical decision support, there are these 5 rights. So it's the right information, right person, right format, right channel, and right time and workflow. So next slide. Some examples of these rights are as listed here. So for right information, we want to make sure that we have evidence-based guidelines or publications. For right person, we want to make sure that anyone within the care team has the appropriate visibility of information. So a nurse should be able to see nursing workflows. A pharmacist should be able to see pharmacy workflows. A nurse should not be able to verify medications. There are certain things they need to make sure that functionalities align. Next, we have right format. So appropriate display. Some things might work better as alerts that are more passively or inline. Some things might need to pop out at your screen. There can be reports or order sets that you place in. So there's a lot of different ways to display the same material to end users, as we put it, or to people working with the patient records. Then there's right channel. So there's different ways to provide the information. So we have apps, we have the electronic health record, we have other platforms that we can use. And then right time and workflow. This matters very significantly because we don't necessarily want something flagging at order entry when we would need to have this information available at opening the patient chart. So if you need to know that the patient is on a ketogenic diet prior to monitoring the patient, that's something that might need to be available upon opening the patient chart, as opposed to at the very end of your workflow when you've already taken and invested all that time into monitoring the patient, and you only then notice that the patient is ketogenic. So there's a balance of finding the right time to provide the information. Next slide. There are some challenges with this. So as I mentioned, I wanted to go over the both the positives and the difficulties of implementing clinical decision support tools. So one is demonstrating value. It's difficult to measure this information and the impact it has on patient care. Some things intuitively make sense for us to have because we've used these health records so much it seems intertwined with our workflow, but there's more work that's being done to try and show how we're trying to improve patient outcomes or mainly prevent safety events. So some solutions to demonstrating value are to show how much money is saved per quality of life year quality for the safety events that we might be avoiding. Next slide. There's also significant alert fatigue. I'm sure people are well aware of some pop-ups or certain alerts that that drive you wild during your monitoring, but there's a balance to this as well, and so it's a constant challenge to try and figure out what the ideal mix is of alerts that are important to prevent those safety events and the amount of time that they're overridden. So commonly, alerts do get overridden about 50 to 95% of the time. Ways to find solutions around this is to make them more specific. So oftentimes they lack a specificity to the specific patient population that it would be impacting. So trying to work with your informatics teams to create alerts that can narrow down the subset of patients that it fires at. If the information is unclear or unnecessary, this also points back to the time and workflow. If this isn't triggering at an instance where you find the information needed, then it might be left ignored. If the information is unrelated to the patient context, so again, narrowing the subset of patients that affect this alert or that have this alert flag. And then passive versus actionable. So this one has the most benefit because oftentimes we can evaluate clinical alerts and find solutions to where we can point practitioners and healthcare workers to the right information by, say, in the case of our vaccination protocol, providing order entry directly into the BPA. So streamlining workflow as opposed to creating more. Next slide. End user satisfaction is a big one. So having people that are interacting like yourselves, like pharmacists, having people who are interacting with the software be comfortable with using it and have it add to the experience as opposed to detract is really important. So a lot of management support and user training up front is needed, and making sure that the system is maintained appropriately and has the most up-to-date evidence really helps people feel more feel that the information is more validated and more useful to them. Next slide. So this leads us to the second question. Which of the following are part of the 5 rights of CDS? Is it A, information, B, person, C, time and workflow, or D, all of the above? Yep, so next slide. D, all of the above is correct. So there's multiple components of that go into clinical decision support. Next slide. So now we come to the last component, which is applying what we had discussed about some of the caveats and clinical gray areas of renal function estimation as a whole, as well as what the initial steps are to creating clinical decision support. Now we can try and select the optimal clinical decision support for renal function. Next slide. So why does choosing the right tool matter in the first place? So display is very important as one of the rights. We need to make sure that we're displaying this information in a way that is very user-friendly. And we also need to make sure that we balance that with content that can be easily maintained on the informatics end to make sure that this can be validated and updated whenever new material is presented. And so trying to minimize clutter in the system while maximizing the amount of clinical content available is really the fine balance that we have. So next slide. And this is very well identified in a recent publication from Brigham and Women's. There was an analysis of their renal dosing alerts, and they did best practice advisories, or the pop-ups that you often see within Epic. They had identified that 100% of them were overridden. And so that's something that we want to try and minimize in our system, because that's not providing value, that's providing more clutter. Next slide. So there's several types of ways to display information, and I'll go through a few with some visuals here. There's the first way that you can potentially provide renal dosing information is in the form of order entry reports. And as you see in this example, you have a table of information from this particular academic medical center that utilizes these on their renal dosing adjustments for acyclovir. You're also able to provide different content in the form of labs within the order entry itself. So if you go to the next slide, I highlight the table to the left and the labs to the right. So you can put in any free text or any information that you want at order entry. So it can provide some useful, some of that non-integrated evidence-based information to providers. Next slide. Next, we have the dosing alerts. So apologies, I didn't fix the title here, but essentially the benefits of having a dosing alert is that you are able to identify if the medication is exceeding what is typically standard. The downside is that these are often hard to target, and you'll often need to enter in a new order if you need to make any sort of adjustments. So it's harder to make it more of an actionable alert, but there are ways to go around it. You can potentially find ways to combine different clinical decision support tools to populate information into order entry to make it a little more seamless. Next slide. We also have best practice advisories. So these are the either pop-ups or inline information that you find that target information to direct clinicians to the appropriate orders. The downsides are that these often do have high override rates. Then they also, as referenced in the Brigham and Young study, can worsen alert fatigue. So we definitely want to balance the amount of alerts that we have with different tools that we can use to provide that information. Next slide. Now, here we have one of the last types of CDS tools that we'll be showing, which is a patient column. So in this case, we're able to, on our end, we're able to identify medications from a list that might be worth looking into or delving into more, and having that information available at the broader level at the patient columns whenever you're fully looking through your patient list. So this has a more global view of the patient, but it can clutter the display. So we have a limit to the amount of columns that we can have at this master list view. 25 tends to be the limit. So you really have a limited amount of real estate to work with. So oftentimes certain other information that's just relative at baseline, such as bed, patient name, and admission date, those sometimes take precedence over some of the clinical decision tools that we might be able to put in place. Next slide. The very last tool that's available that's been utilized significantly in renal dosing is context rules. So this provides specific order defaults based on certain criteria that we have set. So in one case, we could have gabapentin flagged for an otherwise healthy individual, but if their renal function plummets during the stay and the patient has this medication reordered again, if you go to the next slide, it could have some of the dosing buttons not available for view. Now, there's other things that could be modified as well. You could have different dosing button defaults. And this certainly doesn't mean that the types of medication doses doesn't necessarily have to be restricted, but the buttons and the defaults are often what indicate what might be a reasonable range for a certain patient. And so this is one way that that informatics pharmacists have used to try and find ways to present renal dosing information in a different way. So the final question that I have is an all but. So all of the following are functionalities of order entry reports, except A, customized reference material, B, default dose buttons, C, include patient lab values, or D, none of the above. So if you go to the next slide, I use this one to try and trick you all as to show a point that some of these clinical decision support tools are used oftentimes in combination. So the lines can get a bit blurred. So the order entry reports provide a lot of non-integrated information. So they'll show you evidence and they'll lead you to the water, but they won't get the horse to drink, so to speak. So renal dosing contexts are the ones that would change default dose buttons, and contexts in general are ones that would show different defaults. And then if you go to the next slide, attached are my references, and I'll take any questions. Okay, so if you guys didn't catch the CE from before, I think Alex has the slide up there to get the credit. And thanks everyone.
Yep, thanks Jess. And I will just ask for Megan, Anna, and then Jess's content expert to stay on for feedback. Thanks everyone.